Welcome to our review of common drug therapies, an area that makes up a small but important part of your neonatal certification exam. We'll focus on understanding mechanisms of action, clinical applications, and neonatal-specific considerations that tend to appear on the exam. The beauty of pharmacology questions is that they're usually straightforward if you know the material well. Let's build a solid foundation that'll not only help you pass the exam, but also make you a safer practitioner when caring for our tiniest patients. Let's quickly run through what we'll cover. We're focusing on drugs that show up most frequently on the exam. Cardiac medications are a major area to master. Expect questions about inotropes, drugs for ductal-dependent lesions, and treatments for pulmonary hypertension. Antimicrobials represent another significant chunk of testable content, particularly initial therapy for early-onset sepsis. You'll also need to know pain management medications, diuretics, drugs for patent ductus arteriosus, and key respiratory medications like caffeine and surfactant. For each drug category, I'll highlight what's most likely to appear on the exam and what clinical nuances might trip you up. Let's get started. Cardiac medications represent the largest category of pharmacology questions on the exam. You absolutely need to know these. The major subcategories include inotropes and vasopressors, like dopamine and dobutamine, which you'll use for blood pressure management and improving cardiac output. Prostaglandin E1 is critical for ductal-dependent lesions and is probably the single most important cardiac drug to understand. You'll also see questions about antiarrhythmics, particularly adenosine for SVT. Questions about sildenafil and inhaled nitric oxide for pulmonary hypertension are also common. Many of these questions focus on dose-dependent effects or picking the right drug for a specific cardiac condition. So let's look at each key medication in detail. Prostaglandin E1, or alprostadil, is a favorite topic for questions on the exam. The questions are usually about identifying when to start the medication based on the clinical picture and the common side effects. PGE1 mechanism is straightforward. It maintains patency of the ductus arteriosus, which is literally a lifesaver in ductal-dependent cardiac lesions. The most critical side effect to know is apnea, which occurs so commonly that many centers will prophylactically intubate babies before starting PGE1. Other side effects include hypotension, fever, and seizures, but examiners love to test on the apnea connection. PGE1 is your first-line agent when you suspect any cyanotic heart defect where pulmonary blood flow depends on ductal patency. The exam commonly tests your ability to recognize situations where this drug is needed urgently. Let's get specific about when you'd use PGE1. For cyanotic lesions, think of transposition of the great vessels, where mixing depends on the ductus. Pulmonary atresia, where pulmonary blood flow relies on the ductus. Tetralogy of Fallot in severe presentations. And tricuspid atresia. For acyanotic lesions, think coarctation of the aorta and interrupted aortic arch, where systemic blood flow beyond the obstruction depends on the ductus. Here's a high-yield clinical pearl. If you have a cyanotic neonate not improving with oxygen, think ductal-dependent lesion and start PGE1 immediately while arranging for echocardiography. The exam often tests this urgent clinical scenario. Don't wait for the echo if you suspect a ductal-dependent lesion. Start PGE1s immediately. Dopamine questions appear frequently on the exam, especially regarding its dose-dependent effects. This is absolutely something to memorize. At low doses, 0.5 to 3, dopamine primarily affects dopaminergic receptors, increasing renal blood flow and urine output. At medium doses, 5 to 10, you get cardiac effects through beta-1 stimulation, increasing heart rate and contractility. At high doses, over 10, alpha effects predominate, causing vasoconstriction. The exam loves to test this dose-effect relationship. You'll need to monitor heart rate, blood pressure, and urine output carefully, as well as monitoring the IV site. When calculating infusion rates, double-check your math. Errors here can be catastrophic in tiny babies. Dobutamine is another inotrope you'll need to know well. Unlike dopamine, it works primarily through beta-1 stimulation to increase cardiac contractility. It's especially useful in cases of cardiac decompensation or cardiogenic shock. The key comparison with dopamine is that dobutamine provides better improvement in cardiac output with less peripheral vasoconstriction and typically causes less tachycardia. This makes it particularly useful when you need to improve contractility without dramatically increasing afterload. You'll need to monitor blood pressure, EKG, and heart rate during administration. Always administer through a large vein to avoid extravasation injury. The dose range is typically 2 to 20, titrated to effect. Epinephrine is critical to understand for both resuscitation and continuous infusion scenarios. It stimulates alpha, beta-1, and beta-2 receptors, which is why it's so versatile, but also potentially dangerous. For neonatal resuscitation, know the dose, 0.1 of the 1 to 10,000 solution. Although current practice recommends a standard dose of 0.2, but exam questions are usually focused on the when, why, and how, not the specific dose. For continuous infusions used in shock or post-resuscitation, you'll typically start at 0.05 to 0.1 and titrate by 0.01 increments. Watch for excessive vasoconstriction, causing poor peripheral perfusion, and always monitor for extravasation, which can cause tissue necrosis. In practice, this is often our third-line agent after dopamine and dobutamine, but it's incredibly effective when needed. Norepinephrine is becoming more common in neonatal units for persistent shock, especially septic shock and pulmonary hypertension with circulatory failure. Its mechanism favors alpha effects over beta, giving strong vasoconstriction with some increase in contractility and heart rate. The key difference from epinephrine is that norepinephrine causes more vasoconstriction and less tachycardia. This makes it particularly useful in septic shock, where you have vasodilation and need to increase systemic vascular resistance. Monitoring is absolutely critical. Watch blood pressure, heart rate, peripheral perfusion, and urine output. Extravasation can be devastating, so ensure proper IV placement, preferably central access. Typical starting dose is 0.05 to 0.1. When you're studying cardiac medications for your boards, here's a critical point to remember. Always answer based on national guidelines, not what your hospital actually does in practice. I know this sounds counterintuitive. Your attending might be using the latest protocols based on cutting-edge research, and they're probably right to do so. But here's the catch. Exam questions have a massive lag time. They're written, reviewed, and vetted years before they appear on your test. So, while your institution might be implementing superior evidence-based practices from recent trials, the exam is still testing you on guidelines that were standard 2 years ago. The question writers were working with older ACC and AHA recommendations when they developed these questions. You may see a question about the management of supraventricular tachycardia. Adenosine is your first-line agent for supraventricular tachycardia in neonates. It works by temporarily blocking AV node conduction, interrupting the re-entry circuit, causing the tachycardia. The starting dose is 0.1, which can be increased if needed. The administration technique is crucial. Give as a rapid IV push, followed immediately by a saline flush. It has an extremely short half-life of just seconds, which is why the fast push and flush are necessary. When this process happens, the EKG will flatline briefly, then restart into a rhythm, hopefully sinus. Always monitor with continuous EKG during administration. Side effects include transient heart block, that's actually the intended effect, and sometimes bronchospasm. Lastly, when questions appear about SVT, start treatment with less invasive methods, like vagal maneuvers, before resorting to adenosine. The only exception to this is if the infant is symptomatic, which is usually indicated by hypotension and clinical symptoms. Persistent pulmonary hypertension of the newborn, 6 requires specific medications that target pulmonary vasculature. Sildenafil has become a mainstay treatment. It works by inhibiting phosphodiesterase 5, which increases cGMP and promotes pulmonary vasodilation. It can be given orally or IV. Milrinone is another option, acting as a phosphodiesterase 3 inhibitor that reduces afterload while improving contractility. It's particularly useful in PPHN when cardiac function is preserved. Inhaled nitric oxide is the gold standard treatment, providing selective pulmonary vasodilation without systemic effects. We'll talk more about INO when we cover respiratory medications, but remember that it's specifically indicated for hypoxic respiratory failure with evidence of pulmonary hypertension. Hypertension in neonates is uncommon, but needs prompt treatment when it occurs. Hydralazine is a direct vasodilator available in both oral and IV forms. It's often used for urgent blood pressure reduction. Labetalol combines alpha and beta blocking effects, making it effective for hypertension, but you need to monitor closely for heart failure, which would be a contraindication. ACE inhibitors like captopril and enalapril are used for chronic management. The key point to remember is that first-dose hypotension is common, so start with lower doses and monitor blood pressure closely. You'll also need to watch renal function and potassium levels, as these drugs can cause hyperkalemia. These medications appear less frequently on the exam than inotropes, but are still important to understand. Antimicrobials represent another significant portion of pharmacology questions on the exam. The combination that appears most frequently is ampicillin plus gentamicin for early-onset sepsis. Know this partnership well. The questions may appear as recall, such as identifying the antibiotic indicated for an infant with an infection caused by a specific pathogen, or evaluation, where it describes an infant with a clinical picture, and you need to determine the most likely pathogen and appropriate medication. You'll need to understand different classes of antibiotics, beta-lactams, like ampicillin, that target cell wall synthesis, aminoglycosides, like gentamicin, that inhibit protein synthesis, and vancomycin for resistant gram-positive organisms, especially coagulase-negative staph. Antiviral agents like acyclovir for HSV infections also appear on the exam. I'm going to focus our discussion on the most frequently tested antimicrobials, starting with the penicillins and ampicillin. Penicillins, particularly ampicillin, are cornerstone antibiotics in neonatal care and frequently tested on the exam. Their mechanism of action involves inhibiting bacterial cell wall synthesis by interfering with the transpeptidation reaction. Ampicillin is your go-to for early-onset sepsis coverage, typically paired with gentamicin. It covers many gram-positive organisms, some gram-negative organisms, and Listeria monocytogenes. That's why it's preferred over penicillin G for neonatal sepsis. The clearance is primarily through renal excretion, so you'll need to adjust dosing in renal impairment. Watch for allergic reactions, though they're uncommon in neonates. Ampicillin dosing is weight and age dependent, so make sure you're familiar with the appropriate dosing schedules. Gentamicin is the most commonly used aminoglycoside in neonates. It works by inhibiting bacterial protein synthesis by binding to the 30S ribosomal subunit. A crucial concept to understand is that aminoglycosides exhibit concentration-dependent killing and have a significant post-antibiotic effect. This means higher peak concentrations lead to better bacterial killing, which is why once-daily dosing has become more common. Gentamicin is almost always paired with ampicillin for early-onset sepsis to provide synergistic coverage. The exam frequently tests on this combination and on the monitoring required for gentamicin. Speaking of monitoring, therapeutic drug monitoring is essential. You'll need to check trough levels to prevent toxicity. The target trough is usually less than 2. Nephrotoxicity is a major concern. These drugs can cause acute tubular necrosis. You'll need to monitor BUN and creatinine and ensure adequate hydration. Even more significant is the risk of permanent ototoxicity affecting both hearing and vestibular function. This risk increases with prolonged therapy, elevated trough levels, and concurrent use of loop diuretics like furosemide. The combination of gentamicin and furosemide is particularly dangerous for hearing. Be very cautious when using these together. Neuromuscular blockade can occur, but is rare in neonates. These toxicity concerns explain why we monitor drug levels so carefully and typically limit courses to 48 to 72 hours, unless culture-proven infection requires longer treatment. I'm sure you will see at least one question about vancomycin. This glycopeptide antibiotic inhibits cell wall synthesis in gram-positive bacteria, but works differently than beta-lactams. We use it primarily for coagulase-negative staphylococci, MRSA, and resistant gram-positives. Therapeutic drug monitoring is absolutely necessary. Aim for trough levels of 10 to 15 for serious infections. Inadequate levels lead to treatment failure and potential resistance. The side effects to know include red man syndrome from rapid infusion, not a true allergy, and nephrotoxicity. Always administer over at least 60 minutes to prevent the infusion reaction. Vancomycin is the go-to drug for late-onset sepsis in many NICUs, especially in babies with central lines, so understand its use well. Antifungal agents appear less frequently on the exam, but are still important. Amphotericin B is used for systemic fungal infections. It works by binding to ergosterol in fungal cell membranes, causing cell leakage. Monitor renal function and electrolytes closely, as nephrotoxicity is common. Fluconazole is used both for prophylaxis and treatment of candidiasis. Remember that it's not effective against Candida krusei and Candida glabrata. That's a high-yield fact that might show up on the exam. You'll need to monitor liver function with fluconazole use. For superficial infections, nystatin is the typical choice, used orally for thrush or topically for cutaneous candidiasis. It's not systemically absorbed, which is why it's safer for mucocutaneous infections. Pain management represents a significant portion of pharmacology questions. The exam tests understanding of different pain medication types, from non-pharmacologic interventions like sucrose and positioning to potent opioids like fentanyl and morphine. You need to know that proper pain assessment before and after administration is essential for effective management. The exam might test your knowledge of appropriate assessment tools for neonates. There's always a balance between adequate pain control and potential side effects, especially respiratory depression with opioids. Let's look at specific agents, starting with the simplest intervention, sucrose. Sucrose solution is a fantastic, simple option for brief procedural pain that appears regularly on the exam. Although the exact mechanism isn't fully understood, it's believed to work through endogenous opioid release. The key to effective use is administration timing. Give it about 2 minutes before the painful procedure to allow time for effect. Place it directly on the tongue or buccal surface, and combine with non-nutritive sucking for maximum effect. It is important to remember that sucrose is not effective if given through an NG tube. It needs that sweet taste sensation on the tongue to work. Some providers avoid using sucrose in extremely premature infants, though evidence for harm is limited. It's perfect for heel sticks, venipunctures, and similar brief painful procedures. Fentanyl is a synthetic opioid that is 50 to 100 times more potent than morphine and acts by binding to opioid receptors in the CNS. The advantages of fentanyl over morphine include less histamine release, better hemodynamic stability, and shorter duration. It's often preferred for intubated babies for this reason. The most critical side effect to know is chest wall rigidity, which can occur with rapid IV administration and may require muscle relaxation to allow ventilation. This complication is frequently tested. Always administer slowly to prevent this effect. Fentanyl undergoes hepatic metabolism, so use caution in liver dysfunction. Typical doses are 0.5 to 2 for procedural pain and 1 to 5 for continuous infusions. Morphine is another common opioid. It's used for moderate to severe pain, neonatal abstinence syndrome, and iatrogenic withdrawal. Like fentanyl, it works by binding to opioid receptors in the CNS. Compared to fentanyl, morphine causes more histamine release, which can lead to greater hemodynamic effects, particularly hypotension. It also has a longer duration of action. Critical monitoring includes respiratory status and level of consciousness. Watch for signs of urinary retention and decreased gastrointestinal motility as well. Remember that oral doses are only about half as effective as parenteral doses due to first-pass metabolism. This conversion factor is important to know when transitioning from IV to oral therapy. Diuretics represent another tested category. You'll need to know loop diuretics like furosemide, thiazide diuretics like chlorothiazide and hydrochlorothiazide, and potassium-sparing diuretics like spironolactone. In neonatal care, we commonly use these for BPD, chronic lung disease, congestive heart failure, pulmonary edema, and general fluid overload states. The exam often tests your ability to differentiate between these classes, identify their unique side effects, and understand when combination therapy is appropriate. Let's start with the most powerful diuretic, furosemide. Furosemide is a loop diuretic that blocks sodium-potassium chloride co-transport in the ascending loop of Henle, leading to decreased reabsorption of these electrolytes and increased urine output. The key side effects you need to know are electrolyte abnormalities, particularly hypokalemia, hyponatremia, hypocalcemia, and hypomagnesemia. With chronic use, there's risk of nephrocalcinosis from hypercalciuria. Another serious concern is ototoxicity, especially when combined with aminoglycosides. Routes include IV and oral, but they're not interchangeable due to different bioavailability. IV has a much faster onset of action compared to oral administration. Careful monitoring of electrolytes, renal function, and hearing is essential with chronic use. Thiazide diuretics like chlorothiazide and hydrochlorothiazide work by blocking sodium reabsorption in the distal tubule. The key difference from loop diuretics that you need to know is that thiazides decrease calcium excretion. They're calcium-sparing, while loop diuretics increase calcium excretion. Thiazides are less potent than loop diuretics but have a longer duration of action. They're particularly useful in chronic conditions like BPD when longer action is beneficial. The main electrolyte concern is hypokalemia, so monitoring potassium levels is essential. Thiazides also tend to cause less metabolic alkalosis than loop diuretics, which can be beneficial in some cases. Combination diuretic therapy is a concept that might appear on the exam. When we combine a loop diuretic with a thiazide, we get a synergistic effect through what's called sequential nephron blockade, blocking sodium reabsorption at multiple sites in the nephron. A common combination is hydrochlorothiazide with spironolactone, which provides effective diuresis while minimizing potassium losses. Spironolactone is a potassium-sparing diuretic that works by blocking aldosterone receptors. With combination therapy, you need to monitor electrolytes more frequently. Avoid combinations in renal dysfunction as the risk of complications increases. The synergy between diuretics can be powerful, so start with lower doses when using combinations. Patent ductus arteriosus management is a high-yield topic. The primary medical treatments are prostaglandin inhibitors, specifically Indomethacin and ibuprofen. Both work through the same mechanism. They inhibit cyclooxygenase, which reduces prostaglandin production. Since prostaglandins help keep the ductus open, inhibiting them promotes closure. These medications achieve closure in about 70 to 85% of cases. The dosing schedule is critical. Typically, 3 doses given at 12 to 24-hour intervals depending on urine output. If medical management fails, surgical ligation becomes necessary. Let's look at Indomethacin, which is the most frequently tested PDA medication. Indomethacin is a primary PDA closure agent. As a COX inhibitor, it reduces prostaglandin synthesis to promote ductal closure. Beyond PDA closure, Indomethacin has an additional benefit of reducing intraventricular hemorrhage risk when used prophylactically. The contraindications are frequently tested. Know these cold. They include renal failure, thrombocytopenia, platelets less than 50,000, active bleeding, necrotizing enterocolitis, and severe sepsis. The typical dosing is 0.1 to 0.2 per dose for 3 doses, but the specific regimen depends on age and weight. This drug works well, but comes with significant side effect concerns. The details of Indomethacin administration are highly testable, specifically when to stop treatment because of side effects. One key point is adjusting the dosing interval based on urine output. If urine output is less than 0.6, or if anuria develops, you should hold the dose. The side effects you absolutely need to know include decreased renal blood flow leading to oliguria, reduced cerebral blood flow, potential concern for brain perfusion, risk of GI perforation, and platelet dysfunction leading to bleeding risk. Monitoring should include BUN, creatinine, platelet count, urine output, and follow-up echocardiograms to assess treatment effectiveness. The renal effects are usually transient, but can be significant, which is why monitoring urine output is so important. Ibuprofen is an alternative to Indomethacin for PDA closure with similar effectiveness. Both drugs inhibit cyclooxygenase to reduce prostaglandin synthesis. The key difference that might appear on the exam is that ibuprofen has less effect on renal blood flow and cerebral blood flow compared to Indomethacin. This makes it potentially safer in babies with marginal renal function or neurological concerns. However, ibuprofen has the same contraindications as Indomethacin: renal failure, thrombocytopenia, active bleeding, NEC, and severe sepsis. You'll still need to monitor renal function, platelet count, and signs of bleeding during treatment. The typical dosing is an initial dose of 10 mg per key, followed by 2 doses of 5 mg per key at 24-hour intervals. Anticonvulsants appear regularly on the exam. Phenobarbital remains the first-line agent for neonatal seizures, despite its limitations. Second-line options include levetiracetam, Keppra, and phenytoin-phosphenitoin. For emergent treatment, benzodiazepines like lorazepam may be used, but they're not ideal for ongoing seizure management in neonates. In rare cases of certain seizure types, pyridoxine, vitamin B6, can be diagnostic and therapeutic, particularly in pyridoxine-dependent seizures. Monitoring is critical. You'll need to track EEG response, medication levels, and respiratory status, as many anticonvulsants can cause respiratory depression. Phenobarbital works by enhancing GABA-mediated inhibition in the brain, decreasing neuronal excitability. The loading dose is a high-yield fact. 20 IV is the standard initial dose for seizures. Maintenance dosing typically starts at 3 to 5. The therapeutic level range is 20 to 40. An additional benefit worth knowing is that phenobarbital enhances bilirubin clearance by inducing glucuronidation enzymes, which can be helpful in babies with hyperbilirubinemia. The main side effects are respiratory depression and sedation, so monitor respiratory status carefully after administration, particularly after the loading dose. Phenobarbital has a long half-life in neonates, allowing for once-daily dosing. Levetiracetam is an alternative to phenobarbital. Its mechanism involves binding to synaptic vesicle protein 2A, though the exact way this controls seizures isn't fully understood. The main advantages over phenobarbital are less sedation, fewer cognitive effects, and a better overall side effect profile. This is particularly important for long-term therapy. It's available in both IV and oral formulations, which makes transitioning from acute to chronic management simpler. Typical loading doses are 20 to 50 with maintenance of 10 to 30 twice daily. Although long-term data in neonates remains limited, many centers are now using levetiracetam as either first-line or early second-line therapy due to its favorable safety profile. Levetiracetam is an alternative to phenobarbital. Its mechanism involves binding to synaptic vesicle protein 2A, though the exact way this controls seizures isn't fully understood. The main advantages over phenobarbital are less sedation, fewer cognitive effects, and a better overall side effect profile. This is particularly important for long-term therapy. It's available in both IV and oral formulations, which makes transitioning from acute to chronic management simpler. Typical loading doses are 20 to 50 with maintenance of 10 to 30 twice daily. Although long-term data in neonates remains limited, many centers are now using levetiracetam as either first-line or early second-line therapy due to its favorable safety profile. Respiratory medications make up another important category for the exam. You'll need to know bronchodilators like albuterol and ipratropium, though they're used less commonly in neonates than older children. Respiratory stimulants, particularly caffeine citrate for apnea of prematurity, are highly testable. Surfactant therapy is essential knowledge for any neonatal practitioner. Inhaled nitric oxide for pulmonary hypertension crosses over with our earlier cardiac medication discussion, but is primarily considered a respiratory therapy. Finally, you should understand the complex risk-benefit profile of corticosteroids for various respiratory conditions. Let's dive deeper into these medications. Caffeine citrate is the primary therapy for apnea of prematurity and a high-yield medication for the exam. It works through multiple mechanisms, antagonizing adenosine receptors, increasing respiratory center sensitivity to CO2, and enhancing diaphragmatic contractility. The therapeutic level is 8 to 20, though many units don't routinely monitor levels unless there's concern for toxicity or lack of effect. The loading dose is 20, followed by maintenance doses of 5 to 10 once daily. Beyond treating apnea, caffeine has been shown to improve outcomes in preterm infants, leading some to call it a lung and brain protector. It facilitates extubation and may reduce the incidence of bronchopulmonary dysplasia. Side effects include tachycardia, feeding intolerance, and jitteriness, but these are typically mild at therapeutic doses. Surfactant therapy is essential knowledge for the exam. The two main types you'll need to know are Buractant, Survanta, and Poractant alpha, Curosurf, both used for treating respiratory distress syndrome in preterm infants. Administration is via the endotracheal tube, and the critical monitoring afterward involves watching for rapid changes in oxygenation and ventilation requirements. You'll need frequent blood gases after administration, as lung compliance can improve dramatically and quickly. A key practice point: avoid suctioning for at least 1 hour after dosing to prevent removing the administered surfactant. Potential complications include pulmonary hemorrhage and transient airway obstruction. The dosing, timing, and number of doses vary by product and clinical situation, but the principle remains the same: replacing deficient natural surfactant to reduce surface tension in the alveoli. Inhaled nitric oxide is a selective pulmonary vasodilator used for hypoxic respiratory failure associated with pulmonary hypertension. It works locally in the pulmonary vasculature, causing vasodilation without systemic effects. It must be delivered using a special system, typically the Inomax DSIR system, that can accurately deliver and monitor the gas. The typical starting dose is 20 ppm. Monitoring is critical. Check methemoglobin levels within 4 to 8 hours of starting therapy and regularly thereafter. Also, monitor oxygenation through the oxygen index and watch nitrogen dioxide levels. When discontinuing INO, you must wean gradually to prevent rebound pulmonary hypertension. This typically involves stepwise reductions in dose rather than abrupt discontinuation. Sedatives and hypnotics appear less frequently on the exam, but are still important to understand. Midazolam, Versed, is a short-acting benzodiazepine sometimes used for brief procedural sedation. However, there are significant concerns about neurotoxicity in premature infants and risk of hypotension. Lorazepam, Ativan, is a longer-acting benzodiazepine that may be used occasionally, but it carries risk of respiratory depression. Chloral hydrate was once common for procedural sedation but has fallen out of favor in modern practice. It's worth noting that many centers are moving away from pharmacologic sedation in neonates whenever possible due to concerns about neurodevelopmental effects. Midazolam requires special caution in neonates. Like other benzodiazepines, it enhances GABA receptor function in the brain, but this mechanism raises serious concerns in the developing neonatal brain. The biggest concern is neuroapoptosis, or programmed cell death that may be triggered by GABA-enhancing drugs in the developing brain. Several studies have shown adverse neurodevelopmental outcomes without clear clinical benefits. Hypotension is common with rapid administration, so if it must be used, give it slowly. Respiratory depression is always a risk, particularly in preterm infants. If you do need to reverse midazolam effects, flumazenil is the antidote, but it's rarely used in neonatal care. The bottom line: there are very few good indications for benzodiazepines in neonates, and many centers have removed them from routine use. Gastrointestinal medications appear occasionally on the exam. Histamine H2 antagonists like ranitidine and famotidine reduce gastric acid production but carry significant cautions in very low birth weight infants. Proton pump inhibitors like omeprazole and lansoprazole more completely suppress acid but have limited neonatal indications. Recent research has questioned the routine use of acid suppression in neonates. Prokinetic agents like metoclopramide and erythromycin are sometimes used for feeding intolerance or gastroesophageal reflux, but evidence for their efficacy is limited, and they carry significant side effect concerns. These medications should generally be used judiciously in the NICU population. A critical concept to understand is the risk-benefit profile of acid suppression medications. H2 blockers like ranitidine have been associated with a 6-fold increased risk of necrotizing enterocolitis in very low birth weight infants. This is a high-yield fact for the exam. They're also linked to increased infections, likely due to altered gut microbiome and reduced acid barrier function. If used, monitor gastric pH to ensure it's above 4. Proton pump inhibitors carry similar concerns, plus potential for reduced bone mineralization with long-term use. If these drugs are used chronically, consider vitamin D and calcium supplementation. The most important question to ask before starting these medications is whether acid suppression is truly necessary. In most neonatal cases, it isn't, and the risks often outweigh the benefits. Erythromycin is sometimes used as a prokinetic agent to stimulate gut motility, though this is an off-label use. It works as a motilin receptor agonist, stimulating gastric emptying and intestinal contractions. The critical association you need to know is the 10-fold increased risk of pyloric stenosis in infants under 14 days old receiving erythromycin. This side effect is highly testable. Despite its theoretical benefits, erythromycin has shown limited efficacy in most clinical trials for feeding intolerance. It's not recommended as a routine prokinetic agent due to this poor efficacy combined with the pyloric stenosis risk. Its primary appropriate use in neonates is as an antimicrobial for specific infections, not as a prokinetic. Corticosteroid use in neonates is complex and nuanced. The main types you'll encounter are dexamethasone for bronchopulmonary dysplasia, hydrocortisone for adrenal insufficiency or refractory hypotension, and betamethasone given antenatally for lung maturity. Each carries a balance of benefits and significant risks. The approach has evolved toward using the lowest effective dose for the shortest possible duration. Consider the difference between short-term benefits, like improved lung function, and potential long-term risks, like neurodevelopmental concerns. The exam often tests your understanding of these trade-offs and the appropriate indications for steroid therapy. The risk-benefit profile of steroids for bronchopulmonary dysplasia is a high-yield topic. Dexamethasone, particularly at higher doses, over 0.5 milligrams per kilogram per day, has been associated with poor neurodevelopmental outcomes and increased cerebral palsy risk. Current practice favors lower doses for shorter courses only when the respiratory benefits clearly outweigh the risks. Typical candidates are ventilator-dependent infants at high risk for chronic lung disease. Hydrocortisone is being studied as a potential alternative with possibly fewer side effects, though it carries risk of gastrointestinal perforation, especially when used concurrently with Indomethacin. Regardless of which steroid is used, careful monitoring is essential. Watch for hypertension, hyperglycemia, and effects on growth. Always use the lowest effective dose for the shortest time possible. Medications for neonatal abstinence syndrome will appear on the exam. Morphine remains the most commonly used first-line agent, typically titrated based on withdrawal symptoms using a standardized scoring system like the modified Finnegan score. Alternatives include methadone, which has a longer half-life, requiring less frequent dosing, and buprenorphine, which some studies suggest may lead to shorter hospital stays. Remember that non-pharmacologic measures are essential first-line interventions. creating a low-stimulation environment, frequent small feedings, swaddling, and promoting maternal presence. The goal of pharmacologic therapy is to control symptoms while minimizing medication exposure, followed by a gradual weaning schedule. When comparing medications for NAS, buprenorphine is a partial opioid agonist that has shown promising results in recent studies, associated with shorter lengths of stay compared to full agonists. It also tends to cause less respiratory depression. Methadone has a longer half-life, which means fewer dose adjustments and more stable control, but it has more drug interactions and tends to cause more sedation. Treatment choice should be individualized based on the type of exposure, opioid versus polysubstance, and infant factors. More research is needed on long-term outcomes. Always monitor for overtreatment side effects like excessive sedation or respiratory depression. The goal is symptom control, not complete elimination of all withdrawal behaviors. Let's review the highest yield cardiac drug facts that frequently appear on the exam. PGE1 is first line for ductal-dependent lesions, and its major side effect is apnea. Dopamine has dose-dependent effects. Low doses, 0.5 to 3 micrograms per kilogram per minute, are renal. Medium doses, 5 to 10 micrograms per kilogram per minute, are cardiac, and high doses, less 10 micrograms per kilogram per minute, cause vasoconstriction. Adenosine is first line for SVT with a typical initial dose of 0.1 milligrams per kilogram given as rapid IV push. Dobutamine primarily increases cardiac contractility without as much vasoconstriction as dopamine. PDA drugs like Indomethacin are contraindicated with renal failure, platelets under 50,000, active bleeding, NEC, and severe sepsis. With antihypertensives, remember first dose effects with ACE inhibitors and the need for careful monitoring. For antimicrobials, remember that ampicillin plus gentamicin is first line for early-onset sepsis, and you must monitor gentamicin levels to prevent toxicity. With fentanyl, the critical side effect is chest wall rigidity with rapid administration. For seizures, Phenobarbital remains first line, with a loading dose of 20 milligrams per kilogram. Caffeine is the primary therapy for apnea of prematurity, with both respiratory and potential neuroprotective benefits. With steroids, high-dose dexamethasone carries significant neurodevelopmental risks. For diuretics, always watch for electrolyte abnormalities. And remember that thiazides are calcium-sparing, while loop diuretics increase calcium excretion. These high-yield facts appear repeatedly on the exam and are worth committing to memory. The most common side effect of prostaglandin E1, PGE1 administration in neonates is apnea, hypoglycemia, tachycardia. The correct choice is apnea. This question is testing your knowledge of prostaglandin E1 side effects, particularly the most common adverse reaction. Apnea is the most frequently observed side effect of PGE1, occurring in up to 12 to 20% of infants receiving the medication, and may necessitate ventilatory support. Hypoglycemia is incorrect, because while it can occur with PGE1, it's not the most common side effect. Tachycardia is incorrect, because PGE1 more commonly causes hypotension rather than tachycardia. A 2-day-old neonate with hypotension is receiving dopamine. At which dose range would you expect primarily renal effects? 0.5 to 3, 5 to 10, 10? The correct choice is 0.5 to 3. This question is testing your understanding of dopamine's dose-dependent effects, which is highly tested on the exam. At 0.5 to 3, dopamine primarily affects dopaminergic receptors, increasing renal blood flow and urine output. 5 to 10 is incorrect, because this medium dose range primarily produces cardiac effects through beta-1 stimulation. Greater than 10 is incorrect, because this high dose range primarily causes vasoconstriction through alpha-adrenergic effects. The first-line antimicrobial combination for early-onset neonatal sepsis is ampicillin and gentamicin, cefotaxime, and vancomycin penicillin G, and tobramycin. The correct choice is ampicillin and gentamicin. This question is testing your knowledge of appropriate empiric antibiotic therapy for neonatal early-onset sepsis. Ampicillin and gentamicin is the standard first-line combination for early-onset sepsis, covering the most common pathogens, including Group B Streptococcus, Escherichia coli, and Listeria monocytogenes. Cefotaxime and vancomycin is incorrect because this combination is more appropriate for late-onset or hospital-acquired infections. Penicillin G and tobramycin is incorrect because penicillin G lacks coverage for Listeria and some gram-negative organisms covered by ampicillin. When administering fentanyl intravenously to a neonate, the nurse practitioner should monitor for which critical side effect: chest wall rigidity, hyperglycemia, urinary retention. The correct choice is chest wall rigidity. This question is testing your knowledge of fentanyl's unique side effect profile in neonates, particularly with rapid administration. Chest wall rigidity is a significant and potentially life-threatening side effect of rapid IV fentanyl administration that may require muscle relaxation to allow ventilation. Hyperglycemia is incorrect because fentanyl does not typically cause significant changes in glucose levels. Urinary retention is incorrect because, while it can occur with opioids, it's not the most critical side effect to monitor for with fentanyl administration in neonates. Which of the following is a contraindication for Indomethacin therapy for patent ductus arteriosus closure? Hyperbilirubinemia, platelet count less than 50,000, respiratory distress syndrome. The correct choice is platelet count less than 50,000. This question is testing your knowledge of contraindications for PDA pharmacological management with Indomethacin. A platelet count less than 50,000 is a contraindication for Indomethacin due to the drug's effect on platelet function and increased bleeding risk. Hyperbilirubinemia is incorrect because it's not a specific contraindication for Indomethacin therapy. Respiratory distress syndrome is incorrect because PDA is often associated with RDS, and the presence of RDS is actually an indication rather than a contraindication for treatment.